This whole day is about the value of information and learning how to use information, which again, for nursing, we haven't had information to help inform our practice. And I think this opportunity now to bring information to the practice environment is phenomenal, phenomenal. We're going to spend the next 2 hours hearing about what contribution HOBIC can make to clinical care. And I could introduce this group as the U of T panel. I'm wearing my U of T hat now because all of them did their PhDs at the University of Toronto. And I've known a number of them while they were PhD students. And so I have to say it's great pride that I have. I'm going to turn it over to Linda now, and we look forward to your presentation.
I want to thank the Ontario Ministry of Health and Long-Term Care for their long-time dedication and to this particular project and development of this database. It is an absolutely critical piece to many of our programs of research, and we really are international leaders in this area. So really want to thank the ministry and ICES as well for all their support with this. So overheads. Just as a little bit of background to the types of work we're doing, what you're going to see between the discussions today in this particular session is basically a stream of applied nursing health services research, where you'll see the opportunity for research to influence management or organizational policy decisions. That's the kind of research myself and Joan and maybe Kim's work is leading towards. And as well, researchers that are actually working more at the point of care, and you'll see how this database has the potential for actually influencing evidence-informed decisions at the point of care. So it's taken a while to get there. As you're building the data set, this is the kind of thing that we said was going to happen and will start to emerge. And now you're starting to see the emerging work that's coming out of here. In terms of my own work, what my interests are, obviously I started off doing nurse staffing and trying to link it to patient outcomes without the beauty of a data set like this. And this will be the first time we get to actually test this out. And the people involved in this are Walter, who you've seen as already today, and Xiao Mu. I want to acknowledge her contribution as the analyst on this particular study as well. Just by way of background, there's been a lot of work internationally, particularly in the US, by research scientists like Linda Aiken, who have really looked at the links between nurse staffing levels and patient care or clinical care outcomes, primarily in acute care settings. And the focus of what I'm looking at in this particular study will be in the acute care settings. But as you can see from some of the data that Walter already presented today and the types of outcomes we're looking at, there are opportunities to move beyond that. And from my perspective, we know from the earlier research and the earlier data in this area that models of nurse staffing there has been evidence linking nurse staffing to improved patient outcomes in acute care. And so that evidence, there's probably 10 or 12 years of solid research evidence on that. In Canada, one of the challenges that a lot of executives and nurse managers and leaders face is that they're often citing US data or US sources when they're trying to make an argument about a model of care. And we're hoping to be able to test some of that out in this, using this explicit data and working on some of the variables here. And really, HOBIC provides that opportunity, as you saw from some of the outcomes that Walter was presenting, for us to actually look at whether or not relationships exist between the types of staffing models we are using and particular outcomes. And so what we're setting out to do in the particular study that I'm working on now is look at the different types of nurse staffing models that we can explore, linking the MIS data in the organizations to the HOBIC outcomes. So we've got right now, we've just done a preliminary run of analysis, so we've got about 4 different nursing variables we're looking at, some linked to weighted case, some that are a conglomeration of all registered all nursing staff, RNs only, RNs and LPNs, and some without the actual link to weighted case. And we're looking at, again, the change in the outcome from admission to discharge. And essentially what we're trying to do is look at whether is it feasible to actually link staffing to outcomes, and what'll we find if we do that, and where we're at just in terms of the project. Just begun to conduct the analysis. We've done the first preliminary run of the analysis just over the past week, and we've got about 54,000 patient assessments in that data set that we're running. It's from between June 2008 and March 2001. And at this point in time, it's far too preliminary. It's just underway. We need to go back and look at some of the variables. Some of the staffing variables look like they're too correlated and perhaps washing each other out. So it's just in process, essentially. And what we've done earlier, Walter and I are actually working on an article that we're hoping to get submitted on some of the stuff around therapeutic self-care. So that's one publication that we spoke about last year that we're hoping to get out this year. And as well, one of the first steps in actually using data like this from a researcher's perspective and from a validation kind of perspective is looking at whether the data are behaving the way you expect them to behave, and whether they're sensitive to the outcomes being measured. And that's the work that we worked on over the past couple of years, Walter and myself and Xiaomu. And it just got published in the Journal of Nursing Care Quality. And essentially we looked at the change in admission scores, the change in scores from admission to discharge, and found that there was a difference. So we started out trying to prove that the measures are sensitive to what we're trying to test and measure. And then the next stage will be doing the bigger staffing level studies that we're working on. So that's just a snapshot of the first piece of research we're working on. Before we turn it over to the posse, as Dot suggested, I'm going to invite Liz up to, who's the ICIS scientist at Queen's, who's going to talk about a little bit about the work that the group overall is doing at Queen's.
So my name's Elizabeth Vanden Kerkhoff. I'm a prof at Queen's University, and I'm also an ICIS scientist, along with Joan Tranmer, who's here in the crowd. And Joan and I have been working with some of the newer faculty at the School of Nursing on some of the data at ICIS. And one of the projects that we're working on is working with the HOBIC data set, which is what we're presenting today. So I just want to give you a brief introduction as to how we came about doing this. So we applied last year for an applied health research question. So for funding for an applied health research question, which falls into could fall into one of these 3 categories. In our case, it fell under the topic of research project. And so this is a project that comes from Frontline, essentially. So it has to be something that is relevant to the Frontline and that we realize needs to be addressed. So we got our initial funding back last year to look at pressure ulcers, and that was working with Kevin to look at pressure ulcers in long-term care. And then since that time, working with the other three, we started looking at some of the other data within HOBIC, and in particular related to symptoms, medication, and nursing care, outcomes in long-term care. So currently we started off thinking we'd look at the whole HOBIC data set, and after looking at the first cut of that entire data set, we realized we probably should scale it back to the last few years when we start to see more sites being involved in the data collection, so that we can actually say something that may be generalizable to some of those sites. So we've reduced our time frame from January 2010, and we're hoping to take it to the end of December 2012, but at the moment the data that we're presenting today goes up until March 2012. And for the most part, it's preliminary. So the specific projects that you'll hear about today are pressure ulcer and related skin problems, which Kevin will present, pain and related symptoms, which Rosemary will present, safe medication delivery by Kim, and quality of nursing care outcomes and organizational characteristics, which Joan will present. So we'll start with Kevin.
I want to thank you, ISIS, for funding this project, first of all, and also want to thank you, Liz, for providing the mentorship for the group of us in terms of working with this database. So I think we have some sort of preliminary results that we want to share with you today, and have some dialogue about something that I've been very passionate about clinically in terms of the care and management of pressure ulcers. And I want to sort of tell you that I wear a number of hats in this presentation too, because I'm representing the knowledge user, as Liz mentioned. Part of the project is to make sure this collaboration between the knowledge user and the researcher. So I'm the researcher, I'm also the knowledge user representing West Park Health Center as well. Of course, when we talk about pressure ulcers, hopefully this is not too shocking for most of you to look at wound pictures, because I think it does serve a purpose to really understand the extent of pressure ulcer on individuals suffering from this condition. And pressure ulcer is a significant problem. And there's been some data in the past. There's a national base data that was published back in 2004 by Gail Woodbury and Pam Houghton at Western at that time. And they reported that the general prevalence of pressure ulcer was about 24% across different sectors in the healthcare environments. And more recently, actually, Liz is the lead author on this paper. She estimated there were about 13 to 17% of pressure ulcers looking at the data from 1994 to 2008 in acute care hospital. The problem is some of the data is kind of old, and some of the data is not able for us to compare what's going on across sector between acute care and long-term care and the complex continuum care and home care environment. And that's why we thought that this would be a great idea to get access to the HOBIC data to figure out what's going on across sectors in relation to this pressure ulcer problem. And we also want to sort of look at the characteristics and who's getting pressure ulcer, who's developing pressure ulcers. Looking at a trend, do we see an increase or decrease, or the trend continue to be stabilized over time? We also want to look at the correlation between these, the illness severity, the type of patients, the age with pressure ulcer occurrence. As you know, pressure ulcer is a huge problem, and this is just a diagram just to highlight the various components, impact of pressure ulcer on individual and health system as well. And part of my research portfolio is looking at in relation to pressure ulcer and pain, or chronic wounds and pain, and also looking at the psychological impact on the individual as well. And so the rationale for this research project is basically trying to benchmark the prevalence of pressure ulcers across various health sectors. We want to look at to see where those pressure ulcers located, or where they being looked after across a continuum of healthcare settings. And of course, with the growing concern in terms of patient safety, there's a need to be looking at huge databases like this with HOBIC to look at who are the vulnerable population. What are the gaps in terms of providing care, or can we improve the care of pressure ulcer across different sectors? The purpose is of the study is to describe and outline the scope of pressure ulcer. And again, as Liz mentioned, we look at data from April 2010 to the end of that quarter, which is March 2012. And we want to, part of the proposal, we also want to evaluate the extent of different nursing interventions or preventative measures in preventing or managing pressure ulcers as well. Because when you look at the MDS, when you look at the different types of documentation, there are a number of nursing interventions that people can select to indicate what they're doing to prevent and manage pressure ulcers. Then the question is, a certain set of interventions more effective in managing or preventing pressure ulcers than others. We also want to evaluate the factors that are related to the improvement or worsening of pressure ulcers, because particularly with MDS, there's a way the assessor can indicate whether the pressure ulcer is actually getting better or getting worse. So are there certain intrinsic or extrinsic factors that is influencing whether the person continue to improve or deteriorate over time? So we're curious about some of those factors as well, because perhaps we can look at some of the factors that causing the worsening pressure ulcers and address some of those factors, or enable some of the healing factors to improve pressure ulcer care. So we looked at, in this cohort of data, there were about 32,000 patients or individuals being assessed. And then the following bullets were basically describing the prevalence of pressure ulcers across the different healthcare sectors, with acute care between 3.69 to about 7%, long-term care about 4.5% to 6%, and complex continuing care about 10% to 13%. I sort of bracketed home care because when we looked at the data, there was quite a number of missing data. So for the following analyses, I just exclude home care for now, but we want to go back to definitely look at what's going on with the home care data. So to describe in the graph, I think it's easier to get a sense in terms of the prevalence rate and the comparison across different sectors. I was actually surprised to see that there's such a high volume of pressure ulcer in the complex continuing care. Liz said that, well, you should not be surprised, they're more complex, right? But I thought, well, there will be more patients with wounds in the acute care environment, because we always blame acute care for causing those pressure ulcers, right? But anyway, so there's the data. But I think that's not the end of the story. I want to come back to talk about in terms of the transitions at some stage. But that's the prevalence data. We did the post hoc analysis based on the ANOVA, looking at the percentages, and definitely with the Bonferroni method, we're able to identify that complex continuing care patients or that environment has a high volume of people with pressure ulcers than any other settings. This slide is off a little bit, but basically just trying to look at some of the relating factors for the development of pressure ulcers, and this slide looking at complex continuing care, comparing people who have pressure ulcers and people who did not have pressure ulcers. You can see there's actually not much of a difference. We looked at the standardized difference and calculated the mean as well, and none of those numbers actually above 0.2, so the effect size is actually quite small. So basically there's really no significant difference between pressure ulcer patients and no pressure ulcer patients. But the interesting thing is when you look at acute care, you can see the trend here, the differences between pressure ulcer patients and no pressure ulcer patients, particularly in terms of age. People who had pressure ulcers, they're much older. They have a higher Charlson index, meaning they're sicker, they have more comorbidities. Particularly when I look at the number of different comorbidities, higher number of people with CHF, congestive heart failure, with peripheral vascular disease, with diabetes and complications, and renal diseases. For people who are involved in pressure ulcer care, you know that we often use something called prevalence scale to evaluate the risk for pressure ulcer development. And I think this is a very important slide because when you look at all the 6 risk factors on the prevalence scale, in nowhere did they really mention about severity, sickness index. And in acute care, I think it's relevant in terms of looking at how sick those individuals are and what kind of comorbidities they have in terms of predicting whether they're going to develop pressure ulcer. Again, this is not a predictive model, but I think it does help us to inform us for the next step to look at some kind of models to see what are the predictors for pressure ulcer development. And of course, there are different types of pressure ulcers as well. Stage 1 and stage 2, they're more superficial versus the 3 and 4. Again, the picture is sort of off a little bit. You can't see the deep pressure ulcer there. Thank God for that, right? But anyway, I think it's just to show you that there are two big categories of pressure ulcers. And the good news out of the what we see in terms of pressure ulcer data is the fact that most pressure ulcers were stage 1 and 2, so they're more superficial than deep pressure ulcers. And I think we just need to interpret the results with a little bit of caution here because this is a snapshot of what's going on. So we don't know whether some of those stage 1 and 2 problems may progress to something more severe or whether some of those stage 3 and 4 problems have been around for a long time and they're stalled and not progressing to healing and continue to consume a lot of healthcare resources. Based on the fact that we're not, perhaps because people are not instituting best practices in those in the management of those pressure ulcers. We also look at the number of factors from the HOBIC database as well in terms of the symptoms and also some of the ADL and self-care abilities. So we did the mental health or chi-square test of the independence to see if there's a trend between those variables and pressure ulcers and the type of pressure ulcers, separating them into the superficial and the deep pressure ulcers as well. And definitely all those symptoms, dyspnea, fatigue, nausea, and pain, and some of those self-care, mobility, nutrition, moisture factors have an impact on pressure ulcers. So because the chi-square was the p-value was less than 0.001. So I was curious in terms of, well, are there any differences between the superficial and deep? Are there differences in terms of what are the cells that is contributing to those significant relationships? So so we calculated the standardized residuals as well to determine how influential some of those factors are in terms of determining the significance of that relationship. So dyspnea. I don't think this is going to work, right? The pointer. But anyway, the dyspnea is evaluated on a Likert scale from 0 to 3, with 3 representing the maximum or the worst type of dyspnea at rest. And you can see with superficial type of pressure ulcers that there is a very significant relationship between pressure ulcer and dyspnea, and more so than the deep pressure ulcer. And you can see fatigue, again, is a very significant relationship to superficial pressure ulcer. Which is very, very interesting because we don't often think about fatigue as a risk factor for pressure ulcer development. And definitely pain, and my colleague, Dr. Wilson, will be talking about pain, so I'm not going to talk too much about how pain can influence patient outcome. And definitely, I think echoing what Walter talked about from the self-care and ADL perspective, there are no surprises to me, I think, because when you look at the brain and mobility, bed rest, and activity, they're all key factors in terms of predicting pressure ulcer development as well. So this is basically just echoing and agreeing with some of those risk factors as predisposing factor for pressure ulcer development. But look at the significant level. And again, I'm impressed by the fact that superficial are more sensitive to some of those risk factors than the deep pressure ulcers. Perhaps with the deep pressure ulcers, there are other factors that we're not capturing, such as some of the intrinsic factors in terms of what the patient population is like that predispose them to develop those pressure ulcers, not so much of the extrinsic factors or the nursing factors that we can really change that much in preventing or managing. So implication for practice and policy. I think pressure ulcer is still very common. I think we need to address this problem. That's why we're doing a number of research to continue to capture the trend to look at this problem. There is, from 2010 to 12, I mean, it's a short period of time, we didn't see any significant differences in trend. There's no decrease, no increase. And we hope to continue with the data collection to see a longer period of time to determine if there is any significant change over time. But so far, I think we can say with some confidence that there's really no significant changes, which may not be the very good news for us, because despite the fact that we're doing a lot of things and a lot of the new interventions and services available to different facilities, we're not actually reducing the pressure ulcer prevalence to zero. And of course, I mean, there's a lot of debate where the prevalence rate can be reduced to zero, but at least below 10, especially with the complex continuum care environment. And that goes to the, and I want to refer to the third bullet on this slide here, the complexity of care in pressure ulcers. I think we need to think about why there's a high number of pressure ulcer patients in a complex continuum care environment. Are we addressing the needs? What is the characteristic of the environment that is not conducive to providing optimal pressure ulcer care? Not to say that we're blaming the complex continuum care environment for causing those pressure ulcers, but they're managing their population. So do they receive adequate resources to manage their problem? We need to look at the comorbidities associated with pressure ulcer development as well, particularly with the congestive heart failure, PVD patients, diabetic patients. So we need to take in account of the illness score and the severity of the sickness as well. I think I alluded to this point earlier in terms of how we screen for patients, particularly in acute care. Do we really know who's going to develop pressure ulcers? One analogy I always use when I talk about wound care is when you screen everyone in ICU, they're all at risk. So how do you stratify patients in that environment? All orthopedic patients, they're at risk because they cannot move. So there must be something more, there may be a more sensitive indicator in acute care in ICU that we can use to evaluate the risk for developing pressure ulcer. So I think that that's something that we need to work on in the future. Definitely we need to look at symptoms and pressure ulcer development, and also looking at the impact of functional status on the development of pressure ulcer as well. For future directions, I think we need to look at, of course, with pressure ulcer is somewhat of a blaming game. The long-term care blame the acute care for causing the pressure ulcers, and the acute care blame the long-term care not getting adequate staffing to prevent pressure ulcers. So they're all blaming each other. So I think it would be interesting to look at how patients or residents or people move across the different sectors within the system, and where do those pressure ulcers start and how do they start? I think that's a very key question to answer. I think we also need to validate the data. I think in the States, when they look at some of the MDS data, they correlate that with real-time observation. That will be interesting to look at the possibility of doing some real-time observation and compare to the HOBIC data. And I had some sort of preliminary conversation with some St. Mike's folks here as well in Toronto. I think we need to look at some of the integrated reliability in terms of how people are actually evaluating pressure ulcers. And of course, with the HOBIC data, MDS is a little bit messy right now because clinically we ask people not to backstage. You don't backstage from stage 4, 3, 2, 1 and healed. But with the MDS and the HOBIC data, that's the only way to describe the depth of your pressure ulcer from 1, 2, 3 to 4. So there's a little bit of that disagreement between the clinical evaluation and the how we're supposed to be evaluating and documenting on MDS and HOBIC. I think we need to look at the improvement in pressure ulcer screening and risk stratification and prevention in the future as well. So I think there's a lot of work need to be done around pressure ulcer, and then hopefully we can come back to tell you more about what we have done in next year. Thank you.
I'm Rosemary Wilson, and just like Kevin, I wear a number of hats. I'm also a practicing nurse practitioner in acute and chronic pain management at Kingston General and Hotel Dieu hospitals. So I have a real interest in pain and nausea in particular, and I chose nausea as a symptom because it really is interrelated with the pain experience. One of the reasons I wanted to look at the HOBIC data was because I really want to get some data to inform resource allocation and the maintenance of resources to support patients who have pain and its related symptoms across all of the sectors of care. So pain, this is not news to any of you, is a big, big problem in our society today. 1 in 5 Canadians live with chronic pain. And the older we get, the more pain we have. And it's the most common reason for seeking health care. So it's using up quite a lot of our resources in our scarce healthcare resources. And the indirect costs of pain and direct costs of pain in Canada are over $5 billion every year. And some work that Liz has done in the incidence of prevalence of chronic pain in Canada is wide-ranging, 15 to 66%. And the reason that it has such a wide range is that it's really poorly measured. There's poor sampling survey response rates. I apologize, I usually speak to clinicians, so this is a bit of a departure for me. Pain is not very well documented, and because it's a symptom rather than a disease. And the definitions and the measurement of pain really vary across the different sectors. And again, we have really low response rates in the surveys that we send out. In the United States, the cost of pain is over $40 billion every year. And 59% of those who have chronic pain have to leave their jobs. So the cost to society is significant. Another symptom that is really near to my heart is nausea. And it's largely understudied, except in the post-operative setting. It's different than vomiting, but usually you see nausea combined with vomiting as a one symptom, and actually it really isn't. Vomiting is an action. It's a response to signals from the digestive system and the vomiting center of the brain and the vestibular apparatus in the inner ear. Nausea is a subjective symptom, and it's really linked to pain. And it really does affect quality of life. In fact, Ron Melzack developed a nausea questionnaire, and he said in that initial development of that tool, that the patients that he interviewed would prefer to suffer pain than nausea. So we really don't have much idea of the prevalence of nausea across the sectors of care. We do know that postoperative nausea is a real key factor that limits recovery, and that women are at higher risk, and interestingly non-smokers as well, in the postoperative setting. Some work that we did at KGH with Liz and Dr. David Goldstein showed that our postoperative prevalence for all comers after surgery is about 25%, which is a significant number. And Walter mentioned in his talk that nausea actually is associated with an increased number of readmission rates, so I think it's something that we need to take a look at. So the analysis that we've done for this particular research question includes data from acute care, complex continuing care, home care, and long-term care. Again, I have data from 2010, 2011, and the first 3 months of 2012. I took a very preliminary look at the data here, really pain and nausea across all sectors from a descriptive point of view, and did some comparisons in pain and nausea by length of stay and comorbidity with the Charlson Index across the sectors. So the Charlson Index is, if you're not familiar with it, I'll give you an example. Myocardial infarction gets a score of 1, and metastatic disease from cancer gets a score of 6. So here's my sample. I have quite a lot in acute care, so this is any assessment, so it could be admission or discharge in acute care. Complex continuum in home care and long-term care, I have a fair number there. The average age is 68 in acute care, the median age. Complex continuum and long-term care are our older group of our sample, and home care is very similar to acute care. We have about equal men and women in both home care and acute care, but in complex continuing care and long-term care, we have slightly more women. And the number of admissions, more median admissions in long-term care. So here's a look at pain prevalence, and what this slide really tells you is that what I know from my clinical practice, women have more pain than men across the sectors of care. So for example, in long-term care, 8,153 women versus 4,373 men. And there are more women in long-term care, but this is percentage of women that have pain. So what I did in this particular analysis is I dissected out no pain and then all of the others, so mild pain, moderate to pain, and severe incapacitating pain. So 1, 2, and 3 on the scale for long-term care. Pain is actually measured differently in the HOBIC database amongst the sectors. So acute care is 0 to 10, as we mentioned before. And in the complex continuing home care and long-term care, it's 0, 1, 2, and 3. And there is a composite pain score too for each of those sectors. In acute care, I'm very interested in the pain intensity ratings, and you should know that in clinical practice we're actually moving more to pain-related interference with activity, mostly in the chronic pain setting, because sometimes we find in the clinical practice environment a pain intensity rating alone is not very predictive of patients' ability to do their ADLs or things of that nature. So we're very interested in interference scores. But in terms of pain scores in acute care for all comers, we have a pretty significant chunk of the sample that's having moderate to severe pain. And this is the group of people that I'm very interested in because they represent my client base. So that's over 25% of people in acute care in this sample that have moderate to severe pain. That's a sobering statistic. And here's the comparison with composite pain scores across the other sectors of care. So a fairly good chunk of folks have no pain, but there's really not much difference between mild pain, moderate pain, and severe pain across the sectors. But again, if I draw your attention to the moderate pain, which is pain daily, so it's mild to moderate pain, but pain daily, and severe pain, which is pain daily, so again, it's a very large proportion of the sample, and concerning. Now here's nausea prevalence. This is what I was very surprised at. In acute care, I expected to see quite a lot of nausea in all comers in acute care. I'm not surprised to see that women have more nausea than men across these sectors of care, but I was quite surprised to find the prevalence of nausea in long-term care and complex continuing care. And I could actually buy that in home care, patients would significantly have more nausea because it's perhaps even closer to an admission in an acute care facility, but I think this really cements for me that this is an understudied and under-intervened area of patient care. So TJ Gann and Apfel actually looked at predictive scores for nausea risk. So as I mentioned before, women, and this is consistent with what we found in the database, women are more likely to have nausea than men. In the comparisons that I did preliminarily, there really was no difference in length of stay between pain versus no pain. But I did not dissect out moderate to severe pain in that sample, so that's something I hope to do in the future. And there's no difference in length of stay of nausea versus no nausea in all comers. So you could argue the nausea is actually rated on a 4-point scale, 0 to 3. Clinically, nausea is nausea. You either have it or you don't. So mild nausea can be as incapacitating for some as incapacitating nausea, which is 3. But if we dissected out those who had moderate nausea and incapacitating nausea, we might see a bit of a difference in length of stay, and I am going to look at that. The mean length of stay overall, you can see there. I'm surprised to see that acute care is 1.39 weeks. So this is in weeks. So that's a pretty significant length of time in our sample. When I looked at the Charlson Index and nausea, I was really interested to find that there was a difference, a significant difference in the Charlson Comorbidity Index in complex continuing care, in home care, and in long-term care for the patients that had nausea. So there, and I should point out there was no difference in pain in the sample that I looked at. So again, the dichotomized no pain versus pain, and pain is in the composite score 1, 2, and 3. So, and it subsumes mild pain, so I want to dissect that out and make it more granular in subsequent analyses. The other thing I'd like to point out here is that the 75th percentile for the patients that have nausea is presented there with the little red dot. So in complex continuing care, for example, those who had nausea had a comorbidity index rating, 25% of them had a comorbidity index rating of greater than 5, which is, greater than 5 is a score of a metastatic disease or a number of other comorbidities. So the next steps in this analysis of pain and nausea will involve actually adding other symptoms like fatigue, for example. And I'm interested to hear about the therapeutic self-care at discharge, because I think that'll be interesting too, to look at the subset of patients who have moderate to severe pain and their ideas of their use of medications on discharge from hospital. But I really would like to go on to describe more about the pain and nausea and the clinical characteristics by setting and year. So, how old are they? What surgical groups or medical groups do they come from? And what their healthcare utilization is, and in particular, that group of patients that has moderate to severe pain or moderate to severe nausea, and what they're doing in the healthcare system. I really would like to take a specific look at the patients that have moderate to severe pain in terms of all of their characteristics. So we may need to add some other databases at some point. Okay, and that's it for me.
Hi, I'm Kim Sears. My work is primarily focused on medication safety. So basically, you may be aware of some of these facts, but the research demonstrates that preventable drug-related morbidity and mortality in older adults was estimated to cost $11 billion in Canada, so very significant. In 2007, CIHI reported 1 in 10 adults received the wrong medication or dose. The primary contributing factor was access to drug information. A literature review revealed as many as 28% of all emergency department visits were medication related. And 70% of these were preventable, and as many as 24% were related in hospital admissions, so another huge cost to the system. The research also demonstrates that there's a greater risk of experiencing medication error at points of transition of care, especially true for clients who have chronic disease. The data shows when clients have multiple care providers or on multiple medications, there is a higher risk of experiencing medication error. Medication errors are common, affecting nearly 1 in 5 doses in typical hospital or skilled nursing facilities. A recent review of home care studies showed that the nature of adverse events in homes were identified in as many as 72 studies, and out of that, 44 studies reported different adverse events, and medication management accounted for 59% of all adverse events, so very significant in our home care population as well. So the questions I took to the database didn't relate to any disgusting pictures or nausea and vomiting. So you can rest assured we're clean in this presentation. I'm just joking. So basically we asked 3 questions. Do you know what medications you take? Do you know the purpose of the medications you take? And are you able to take your medications as prescribed? The data points of interest, we're looking at sector. We looked at acute care and home care. We were initially going to look at long-term care, but the data wasn't in long-term care that we could use. We looked at language. Language was not identified, English or other than English. We looked at age in 18 to 85 and beyond. We looked at gender, male and female. Marital status, which was, as you can see, varying degrees of marriage and separation and widowed. And we also we wanted to look at admission and discharge diagnosis, but we were unable to attain it because the data wasn't permitting it. We also wanted to look at education level, and we couldn't get adequate data from that sector or that section as well. So when we look at the not at all and the very much so, I'm happy with Walter's scale, come with the somewhat in the middle, because initially it's not at all and very much so, and then a gradient in the middle. The not at all portion was very small compared to the other portions. In acute care, it was 3.1, and in home care, it was 2.28. So we can say, great, we're doing a wonderful job. However, when we look at actually the people who do not know, that equates to 6,900 people in acute care, and 295 people in home care do not know what medications they are on. So this has substantial impact if we say that errors are substantially related to lack of knowledge on behalf of our clients. When we looked at language, the people who identified they didn't know about their medication had a higher level of not speaking English as their first language. Their age, of course, once we get 85 and beyond, there was a substantial raise in people who didn't know their medications. But also in the 60 to 85 group, there's a substantial number of people that weren't aware of the medications they were taking in both acute and home care. Male and female were similar across sectors and across knowledge of their medications, so it really didn't play in this preliminary study as being a substantial contributor. And marital status, people who are widowed, singled, and married in that order felt that they had a higher portion of not knowing their medication. And if you think widowed is probably our highest age group, that makes sense. So then we asked the question about the purpose that they're taking their medication. And once again, the proportions look smaller, the percentages look small. Acute care 2.96, home care 2.03. But then again, that equates to 6,589 people in acute and 263 in home care. Once again, if language was other than English, that was a contributing factor. And again, our age group, the same findings. The higher your age goes, the less you know about the purpose of the medications you're taking. Male and female, similar cross sectors again, and same outplay for the ages, for the marital status, widowed, single, and married. When we asked, are you able to take your medications? Smaller range again for not at all, but it equates to 5,483 in acute and 192 in home care. So basically, there's more people that are, so this I guess equates to probably about 1,000 or so people who do not know why they're taking their medications, have no idea for the purpose of why they're taking them, but they're taking them. Whether that's a good finding, I don't think so, but anyway. Language, again, non-English speaking was higher. Acute care, age, the same findings. As our age increases, our lack of ability to take our medication increases. Male, female, same, didn't have any real significance in the findings. Marital status, widowed, single, and married were, again, the same order of percentages. So when we look at the findings from the HOBIC data, I just thought it might be interesting to compare findings from the literature. So when we look at sectors, I had just done a study looking at the Commonwealth Fund data, and we had a large database of 9,944 participants from 8 nations across the world. And they identified that, or we identified from the study that self-reported medication errors occurred 4 to 5 times in the community compared to the hospital. So I think there's a huge percentage of area that medications can be occurring in our community settings and in home care, and so we really have to be paying attention to this. Language was identified between the occurrence of medication errors, patient's literacy level and knowledge regarding his or her medications, and this was another finding from the HOBIC data. Age, the US FDA reported that half of fatal medication errors occurred in individuals age 60 and over, and as we were seeing, the lack of awareness of our medications in those age groups increased as people aged. I think that's a substantial impact on our system. Medical errors in the past 5 years revealed that married and never married respondents were more likely to have household errors than divorced, separated, or widowed. Thought that was kind of an interesting feedback, but it didn't really apply to our HOBIC data. And I don't know why. I'm not going to venture a guess on that one, probably. Gender and analysis of 2 databases in the US showed the odds of prescribing an inappropriate medication with a potential to cause an adverse event were doubled in women relative to men. And we saw this too in our analysis from the Commonwealth Fund, that women had a higher risk for medication errors in the community. So in conclusion, language was seen to be a barrier. As a person ages, there's an increased risk of them having more limited knowledge about their medication, the purpose they're taking them, and their ability to take the medications. And in conclusion, there's concern in terms of our aging population, obviously. And when I just did a systematic review on medication safety, and one of the things I found, I was looking primarily at errors, but there was a lot of studies of people going home and family members having to give the patients or their parent or their loved one a medication, and they had no idea what they were giving. They didn't know how to give it. They didn't have the appropriate means to give the medication. So I think with our aging population, there's a lot of areas to explore. The risk of medication delivery in the community is valid, but there's limited research in this area and means to capture the data. So my mom has a medication error at home. I've given her the wrong medication. Where do I report that? Maybe my GP, is it ever followed up? My nurse practitioner, is that reported anywhere? So I think errors are occurring, but we're not tracking them as well. And I think HOBIC is a start, or is one place to identify some of the issues with medication safety. Thank you.
Good morning. I'm Joan Almost, an assistant professor at the School of Nursing at Queen's. I was saying to Dot at the break that her discussing the history of HOBIC actually brought back a lot of reminder of the influence that HOBIC's actually had in my career. Back in 1999, I was a master's student working at Western University and just starting my journey of working for many years as a research director with Dr. Heather Lassinger in the School of Nursing at Western. And one of the first projects we worked on, she was just invited to be part of the expert panel. So I worked for many years in the background for many hours on the expert panel, the lit review, and then I was regional director for the NHOP study in the Southwest region, and eventually co-authored a chapter within the first book on nurse-sensitive outcomes with Diane. And then I worked for many years with Diane as my supervisor for my PhD. So I think the HOBIC was probably very influential. I know it was one of the influences in me choosing to do my PhD way back when I thought I'd never do my PhD. So it's been kind of interesting for me to think about it, and I jumped at the chance when I first started at Queen's, finding out about ISIS at Queen's, and that HOBIC was now available through ISIS, that I jumped at the chance to encourage my colleagues when we were applying for a small internal grant just to think about looking at HOBIC. So I feel like I've come back really full circle working as an RA, doing work for somebody else, to actually being able to do my own research using HOBIC. So my area is a little different than my colleagues, where I'm more interested in the context, the nursing work environment, and the influence that has on patient outcomes. And I've just started going a bit more into area of research around long-term care. That seems to be a sector that I'm being drawn to do more work in. So I thought this was a really good chance to possibly make a link using the HOBIC data to organizational characteristics. So some background around long-term care is that in Ontario there's about 78,000 beds in more than 630 facilities across the province. There's a rising number of residents with comorbidities and chronic diseases. We're an aging population, and that's reflecting in the population within long-term care. And that the majority of the service delivery is provided by a mix of either public, which is government-owned, nonprofit, or private for-profit organizations. So there has been some work done that actually has examined organizational characteristics and patient outcomes. The majority of the research has been looking at acute care, work such as what's been being done by Linda. But there has been some work done within long-term care. And what they found is that nonprofit and publicly owned facilities have higher nurse staffing levels than for-profit facilities, because for-profit is about saving money, so one way to save money is to have less staff. That the higher staffing within those facilities then leads to improved quality of care, and that higher staff turnover in those facilities leads to lower quality of care, and that there was 2 systematic reviews that actually favored nonprofit care delivery. Most of the studies within that was American, so there's a little bit of potential bias there, but there has been other studies done in Canada that really does, again, support the nonprofit care delivery. So what to do with this was my first thought, thinking, okay, HOBIC doesn't really have any of these characteristics, trying to find another data set to possibly within ICIS to link it with. And I was fortunate at the time that there was a study being done through Queen's, being led by Mark Harrison and Rosemary Wilson, that actually was looking at the Southeast LHIN and long-term care facilities in those in the LHIN, which is where Kingston's situated. And part of what they were collecting was some data on things like staffing and profit, non-profit, number of beds, whether there's a nurse practitioner working in the organization or not. So I thought it would be a good chance to actually do some analysis with the HOBIC and then look to see whether there was differences between the 30 facilities. So the purpose of my study was looking at, can HOBIC actually be used to examine important questions about organizational characteristics and the impact that that has on health outcomes in long-term care settings specific to the Southeast LHIN, and also to conduct some initial data quality assessments of the HOBIC database within the long-term care settings. So the overall goal was to link variables within the HOBIC data that are listed there, which is the characteristics of the actual residents and the symptoms, which we've heard a lot about already. And then the KITE study is the one that was being done locally. So as I mentioned, they were looking at designation, number of beds, specialty beds, staffing, and nurse practitioners. So that was my overall goal initially. This is a breakdown of the number of assessments or patients or residents actually based on the LHINs. Not all, there's one LHIN not here, and the number of long-term care sites per each LHIN. And this is basically where my study came to a screeching halt, because as you've looked down at the Southeast LHIN, you can see there's one long-term care facility that collects HOBIC data. So I wasn't able to do any type of a comparison among them. So that was a little disappointing, and it's kind of led to, okay, now what? Great idea, but the data is just not there. So what I'm going to present today is just kind of a general overview of what data is available in long-term care within HOBIC, and not break it down by LHIN or anything. So number of unique patients within the LHIN database within HOBIC is just over 11, almost 12,000 patients or residents. Number of long-term care sites within HOBIC is 123 overall. Average age of the residents is 81, which is a little different than Rosemary's was, which I'm not quite sure why, but we need to look at that. And that there's a majority of females versus the males. Type of institutions that are listed within the database, for some reason there seems to be 36 in ambulatory care, which again we need to really look at why. That doesn't seem quite right, and what's the issue there. But the majority of other residents or patients, residents are basically from nursing homes or home for the aged, based on how the facility's been listed. And then you can see there's about 11% where we can't actually identify what the institution is, which is a large number. I'm not going to present the outcomes that Kevin and Rosemary have already talked about, but I'll present the rest of them. So you can see from here the dyspnea score is majority, just over 70% don't have any dyspnea, and the smaller amount have it at rest, or don't have it at rest, but actually when they actually get up and do something, they feel short of breath. Fatigue. Again, majority haven't had any for the last 3 days, and then a small amount have a minimal and moderate amount. And you can see in both of these slides, you can see that on the left-hand side, it talks about blank, where long-term care is actually pretty good with the amount of missing data. I think we talked about that earlier. There's not a lot of missing data, which is good for us when we do the analysis. And the number of falls, you can see the majority during the past 90 days have had no falls. I was a bit surprised that the number of two was about 25% of residents had about 2 falls during the last 90 days, which seemed a little high for me. So the next steps for me is again, what now? Doing a big, I mean, there's certainly enough data within the actual HOBIC long-term care settings overall, but it's being able to find a database to link it with that could actually provide the organizational characteristic data. Linda talked about the MIS, and I need to look at that a bit more to see whether there's data available there for the long-term care settings that could help me link. And also within, because there's only one facility, you know, it's very limiting within Southeast LHIN, but going possibly to the, you know, the RI data, which has the same variables in it and has much more data available, that might be more applicable to actually if I want to look at my specific LHIN. So I'm going to end with an overall data challenge for all of our studies, what we found in working with our data analysts through ICES at Queen's. One thing that Rosemary found in her study was that for the pain in the non-acute care setting, it seems to jump from no pain to mild to moderate to excruciating. There didn't seem to be quite the stage in between the moderate pain to be suddenly excruciating pain, which seemed quite a bit of a jump. Fair number of missing sites and missing data within those participating sites. We know it's getting better. We keep hearing that year after year, and it seems to be sector specific. Again, the long-term care seems to be pretty good. Other sectors seem to be not so good. And then some of the issues our analysts had with computations is that there's truncating in the LHIN data, so that the ones that start with 1 seem to be mixed up. So even though she was able to give me specific, it seems to be a bit of an issue around being able to differentiate between the different LHINs that start with 1. So you have 1, you know, number 1, and then you have 10 through 13 seem to be very hard to differentiate. That there's variable internal coding systems. Sometimes they use them numeric, sometimes character. And that the Ministry of Health facility number seems to be modified somehow, which makes it a challenge to link data. And then finally, the lack of admission and discharge diagnoses, and if it is there, it's very irregular. So for someone like Rosemary that wants to look at pain, you know, pre and post, and see what their discharge diagnosis is compared to their admission, it makes it a bit of a challenge when it's not there. And then oddness of coding conventions. The one we came across pretty much right away was -1 is either non-assessed pressure ulcer, or it can be those that are so severe that it's not codable. So we aren't able to differentiate whether there's just wasn't assessed or whether it's actually a very severe pressure ulcer. So whether there was some way to separate those out rather than grouping them together. So that's the end of my presentation, and I guess we now open up for questions.